think as we know, telehealth use exploded during the pandemic, and it allowed us to receive care while social distancing. It can also be an important tool to address geographic and financial barriers that contribute to health disparities, particularly in underserved communities. So you can go to the next slide, please. All right, so just to run through, just to get you thinking about sexual and reproductive telehealth. It can be used to address many different sexual and reproductive healthcare needs. That allows patients to connect with a provider earlier, gives access to an expanded network of providers. You can do just individual counseling followed by care, any paperwork to streamline care. You can do like signatures and things like that. Telehealth has been used to remotely monitor, to address the maternal health mortality issues that have increasingly been on the rise, especially amongst Black women in our society. You can do at-home testing and treatment. Like I said, that's could be more of like a hybrid model of care, or you can also send tests to people, and then also provide medications, medication abortion care, and also follow-up care. Next slide, please. So yes, telehealth can be used for medication abortion care. And I state this very specifically because it's very common for people to not even know about medication abortion care at all, or how it works, let alone that it can be provided via telehealth. So medication abortion care is also more highly regulated than other medical services. So that's also why a deeper dive is necessary. So you can go to the next slide. So I'm going to next slide. Great, that's perfect. So I'm going to first give a shout out, especially for these next 3 slides. These are not my own. I received many of this information from Dr. Kristen Brandy from Physicians for Reproductive Health. The slides, a lot of them are from the Guttmacher Institute. And then Diana Green Foster for her work on the Turnaway study, which is a really great book, and that outlines the impacts on people who are denied abortion care. But I'll get to that. So to help level set with abortion care in the United States, about 45% of pregnancies are unplanned or unwanted, and about half of those end in abortion. Abortion is one of the most common medical procedures done in the US, with about 1 in 4 women obtaining abortion care in their lifetime. And then there are also trans men who get abortion care. Next slide, please. So when looking at who seeks abortion care, patients usually identify as young, religiously affiliated, and struggling to make ends meet. While more are white women who seek abortion care, Black and brown women are disproportionately represented as compared to their percentage in the population. And a majority of women who have abortions are already parents. Next slide, please. A medication abortion is done using 2 medications, mifepristone and misoprostol, with the patient taking the mifepristone first and then the misoprostol 24 to 48 hours later. About 80% of medication abortions occur at less than 10 weeks of pregnancy, and that process usually happens in 3 steps. The provider confirms the pregnancy, a patient receiving the medication from a provider receives the medication from a provider directly, like at a clinic or through the mail, and then follow-up care is done to confirm that the abortion was successful. A recent study by the Guttmacher Institute shows that a majority of abortions occur using medication abortion care, and that trend continues to grow. I think it was 56% of abortions occurred via medication abortion. So it's also, medication abortion care is incredibly safe. There's an overwhelming amount of evidence to show that it's safe, and telehealth models allow patients to receive care earlier in their pregnancies, reduce logistical barriers, and it's supported by patients. In fact, major medical organizations like the American College of Obstetricians and Gynecologists have found overwhelming evidence that it's safe and effective. Next slide, please. Abortion is also essential care. Denying a person a wanted abortion can also have negative impacts. And this is the Turnaway study I spoke about, that compared outcomes for people that were able to get a desired abortion and those who were denied care. And it found that those who were denied were 4 times more likely to end up below the federal poverty level and 3 times more likely to be unemployed afterwards. So despite the importance to women's and maternal health, as well as the safety data, medication abortion care is subject to many unnecessary restrictions and regulations. And these happen primarily on three basic levels. With the Food and Drug Administration, the FDA, state law, and the Supreme Court of the United States, or if you've heard me say SCOTUS. Next slide, please. So medications are traditionally regulated by the FDA. When the FDA initially approved medication abortion care in 2000, it limited who can prescribe the medication and how medication abortion can be dispensed. Patients were required to go to a provider specifically certified to prescribe medication abortion instead of their regular medical provider to pick up the pills in person at a clinic or hospital. Next slide, please. And during COVID, there was a decision they were going to review that, and that's really what EMAA worked on, is trying to overturn these restrictions. And then on December 16th, 2021, the FDA did finalize its review, and it overturned the in-person distribution requirement, which made telehealth one-way medication abortion care can be delivered permanently moving forward. So unfortunately, the FDA also added a pharmacy certification piece. And now that's in the process of the back and forth between the FDA and then the manufacturers of mifepristone as they finalize their plans. We are hoping that at the end of the day that, that it won't be limited to mail order pharmacies, that we can also, leave the path open for brick and mortar pharmacy distribution. So if it's better for a patient to pick up the medications at their local pharmacy, like a CVS, that would be possible. And the FDA did make it clear that patients will still be able to pick up medications at a health center if that's what works best for them. And we really do hope that this will reduce burdens on patients who struggle to make ends meet by eliminating unnecessary trips to the clinic, which require time off from work or childcare. Next slide, please. All right, so however, despite these changes, many women will continue to face obstacles to obtaining this FDA-approved medication because lawmakers in most states are imposing medically unnecessary barriers on abortion care. For example, 19 states continue to mandate in-person visits or prohibit telehealth options entirely for medication abortion care. Some states have outdated restrictions on who can prescribe the medication. So even though the FDA says that any licensed healthcare professional can prescribe, some states say that only physicians can prescribe medication abortion when all other medications in that same state may be prescribed by other providers such as nurse practitioners or physician's assistants. 2 states have banned medication abortion use at certain gestations, including Texas, which bans medication abortion care after 6 weeks of pregnancy. And I think Oklahoma has a total abortion ban in place right now. Restrictions also cause unnecessary in-person visits, which especially during COVID resulted in more exposure to disease. Modeling done during the pandemic showed that nearly 2 million clinical contacts could have been avoided during COVID had these restrictions been repealed. Research has also demonstrated that in-person visits are not always necessary for medication abortion care, and that clinical evaluation of a woman receiving such care can be done safely and effectively via telehealth. And importantly, neither FDA restrictions nor state restrictions change the location of the abortion itself, which takes place away from a facility, usually at a patient's home within a few days after taking the medication. And that's regardless of how they receive the medication. It's whether they go to the clinic to pick it up, receive it in the mail, or any of the combination. Next slide, please. So to give a bit of a deeper dive into the telehealth model, it's also subject to state law, as I lifted before. And currently 19 states either ban telehealth for medication abortion or require in-person visits, and those are the red states in this map. The remaining 31, it's allowed for the most part, but there are many other restrictions that exist. Not so many in New York. New York's a pretty good state, but many other states do have restrictions such as waiting period laws or facility requirements or coverage bans on like Medicaid coverage that put barriers in the way between the patient and the time-sensitive care they're seeking. But telehealth is generally still possible in one or more ways in the green states. These restrictions may also cause a woman to delay seeking abortion care. In 2018, nearly 78% of people who'd had abortions ended their pregnancies in the first 9 weeks, and nearly 90% of abortions occurred in the first 13 weeks. According to the Centers for Disease Control and Prevention, 2 of the 3 states with the highest percentage of abortions performed after 15 weeks, so later than average, also happen to have some of the toughest restrictions in the country. For example, Arkansas's governor signed into law a near total abortion ban in March 2021, even in cases of rape and incest. I don't believe that's in effect yet. It's probably still stayed. And then Missouri is one of only 6 states that only has 1 abortion clinic left in the state. By comparison, a study done of over 50,000 women in England and Wales during the pandemic showed that increasing access to medication abortion care with telehealth resulted in patients being able to access abortion earlier in pregnancy. Next slide, please. And so finally, it's the Supreme Court that regulates abortion care. Abortion has been given constitutional protection under Roe v. Wade since 1973. And the Supreme Court is slated to render a decision in the Mississippi case, Dobbs versus Jackson Women's Health Organization, later this month. It literally could come any Monday. Probably the latest would be June 27th. Given the Supreme Court's reaction to the 6-week ban in Texas, they let it stand, even though it was against the holdings in Roe. If you listen to the arguments that took place in Dobbs, really scary. And then the leak, of course, when we received Alito's draft decision, and knowing how the court is stacked with Trump appointees, we're really, really concerned. I guess there's always a chance it won't happen, but we're pretty sure it's going to. That, should say when Roe is overturned, approximately half of the country is poised to outlaw abortion. And these are the orange states that are outlined in this map. And these are the states that are certain or likely to ban abortion. And that means that residents who live in these states will no longer be able to obtain abortion care at all in these states. And this includes the medications that are FDA approved within these states. So the teal and gray states indicate states that are unlikely to ban abortion, with the teal states indicating the nearest provider for people from the states where abortion is banned could travel to in order to get care. So as you can see, for people in the South and then the upper Midwest, the travel distance could be particularly burdensome. And this will put additional pressure on states like New York and clinics who will not be able to meet the needs of New York patients with patients coming in from other states. Just with the Texas ban that has been in place, for several months, there are very long wait times in Oklahoma. Well, not anymore, Oklahoma, because it's not happening there. Kansas, Colorado, and even Minneapolis, because that's how far patients are going and how far they're and they're just having to wait. And the patients who live in those states and patients coming from out of that state. And that's only one state that is out that is not providing abortion. And so what happens if Roe is overturned and many states fall is even more dramatic. And I know, as you can see, that this state shows that New York isn't necessarily like the first place patients would go to, and Pennsylvania is more geographically, it's closer to where some of the more restricted states are. So Pennsylvania is very important. But one thing I really want you to think about, because we are so close to Pennsylvania, is that it's only protected by a progressive governor who is term limited this November. And if an anti-choice governor is elected, all bets are off. I mean, I would say that abortion would likely be banned in Pennsylvania. And then New York would become the closest place for many patients to receive care out of state. And I also do want to note, and sometimes, we New Yorkers can get very complacent and think that we live in a very progressive state and we're completely safe. But if an anti-choice majorities are elected in both houses of Congress and our president is anti-choice, we are at a real threat for a nationwide abortion ban. Next slide. And then when viewing medication abortion care through an equity lens, COVID-19 has intensified the barriers that providers and communities already face. Restricting abortion care disproportionately harms communities of color already hit hardest by the pandemic, facing historical structural racism and impacted by social determinants of health. In fact, a recent study in the journal Demography showed that banning abortion nationwide would lead to a 21% increase in the number of pregnancy-related deaths overall and a 33% increase among Black women. Some of this tension can be eased by relaxing existing restrictions on medication, on abortion delivery models, including telehealth. And that also includes issues like expanded broadband and technology access and payment parity. And these are key to serving individuals that underserved both rural and urban communities. So sorry to kind of leave on a bummer note. I'm happy to answer any questions you may have, but I will say that lawmakers should treat medication abortion care as they do all other care, allowing providers to follow FDA guidance and patients to receive standard of care without unnecessary restrictions or insurance bans. So again, thank you for your time. My contact information is on the slide, and I will hand it back to Colleen.
Hey, Dana, thank you so much for that very informative presentation. Several questions jumped to mind, but I guess I won't hog the space. I'll turn it over to Kate Permut, who's the WWA Reproductive Working Group Chair. So I'll turn it over to you, Kate.
Don't go away yet, Colleen. I'm curious to know your questions. If Katie can add you back to the grouping, I feel like we do have time now, and why not have you go first?
Okay. So my question is, what is the likelihood that all of the restrictions will be lifted on these two medications so that they can be available to people all over the country, even in states that ban abortions? Is that going to be possible?
So, when the Supreme Court overturns Roe versus Wade, what that means is it returns it back to the states. And so states get to make the determinations about, FDA sets the floor and then states can add additional restrictions. There are 13 states that have trigger bans in place, and those are bans that, as soon as Roe gets overturned, that means abortion is banned in that state. One of those is my home state of Missouri, where my family lives. And yeah, abortion will immediately become illegal. And then in other states, governors have indicated that they will immediately call special sessions to outlaw abortion as well. Some may wait. But I think that it's going to be a long, hard road back. It's going to take a lot of work. And we either need federal abortion protection, like the Women's Health Protection Act was just voted on and failed. And that's because we need 60 votes in order to get to that point. And we don't have that right now.
Wow. And sorry, I'll ask a follow up. This medication is available by mail order. So do you think there'll be bans on that in those states that ban abortions?
Yeah, so 19, like I said, 19 states ban the use of telehealth, and that includes mail order, because you have to have some sort of visit with a provider to legally be able to get this medication. It's still prescribed. And then it is sent from I shouldn't say just a physician, because like New York allows physician's assistants and nurse practitioners to prescribe this medication as well. Many states do, not all. And then they send it to a mail order pharmacy, and that mail order pharmacy can mail it to a patient at the best location of their choosing. And so that, yes, that would be banned if telehealth use is not allowed. And yeah, so if you legally want to get pills, patients in states that ban medication abortion or ban abortion will have to travel out of state, because remember the rule I laid out at the beginning, which is care is considered rendered where the patient is located. So if patients are physically located in any state where abortion is banned, then abortion's it's going to be illegal to get the pills.
Well, there's always a back door to get stuff. So can we get them from Canada, maybe? I don't know. Just a thought.
Yeah, I mean, like keeping my professional hat on, I have to, there are organizations that, provide access to pills. One of the organizations where you can go and see a lot of, I can put this in the chat. I think this is right. I'll look this up, but it's Plan C Pills. It's an organization that lists where you can get medication abortion care. And it lists, regardless of state, and it lists some risks that you might be taking if you access in a state where abortion is banned.
Okay, thank you.
Yeah, of course.
So back to you, Kate.
Sure. So one of the simplest questions that first came up was, how can we help as New Yorkers? Most of our viewers are here in New York. Be curious, as you're the Director of Innovation and Partnership, what comes to mind?
So, I mean, I think that one of the biggest things that it's going to be needed is money to help people travel from out of state to get to states like New York or states where abortion is not banned. Even if they could get to a border to have a visit, so they could have a visit, like, they could, money to stay at a hotel for childcare, lost wages, all of those supports that are needed. So money is needed. So we all need an excuse to throw a party and get together as, could we get safer and safer? So I'd say get your friends together, and, there's the New York Abortion Access Fund is really great, or the National Network for Abortion Funds always needs help. I can put links to those in the chat too. Take a look at the political environments in the surrounding states, and, you can always go door knock or phone banking, especially, you can do from the comfort of your home. I know that I've called Georgia and Texas and other candidates there personally. So those are probably two of the biggest things that you all can do to help.
Along the same lines as a question in terms of workarounds being developed, in terms of some people, I've heard examples of setting up like a mail service forwarding box or something like that. Does that have potential as a workaround?
Not legally. There's some,
okay.
Yeah, there's some real question about, I mean, I think that people should be given information about what they can do, and then people are going to have to make decisions about what they want to do. It's not going to be legal to, there are questions about mail forwarding and whether it is legal. It is not going to be legal to send somebody abortion pills in a state where abortion is banned. Yeah.
No, because that ties in with the laws also constantly changing. Is there a website or a resource that you would recommend to try and keep track of this really, fluid day by day situation?
So the Guttmacher Institute is, they do a lot of tracking. Let me get that. That's a really good one. And I'll put that in the chat. And then the Center for Reproductive Rights is really good. They have more of a legal angle, and Guttmacher is more like data collection. So they may be slightly different in their analyses of like which states ban and which states. But I think it's going to be pretty clear when another state goes. And you can certainly find information on like exactly which states have trigger bans, and exactly which states are calling into special session, things like that.
Okay, we have a question about specific drugs. So I know you're not a doctor, but given, it says, do the laws that say banning medication abortion specifically apply to the use of mifepristone and misoprostol regime? Because there's been some talk of the effectiveness of another drug, I want to say letrozole with misoprostol. So is that another way of working around these issues? Could other drugs be developed?
Yeah, I mean, I don't know about letrozole in particular. The FDA approved regimen is mifepristone and misoprostol. There are some studies that have also been done on use of misoprostol alone, and that is often used internationally. It doesn't tend to have as high of an effective rate. It's much cheaper to obtain too. It's an ulcer medication, so it doesn't have the same level of restrictions, and there are a lot more manufacturers of it. But it's not the FDA approved method. There are also some equity concerns when we talk about misoprostol alone, because we want patients to get the best care that they need and want for themselves, whether that's an in-clinic surgical abortion, or which is also just as safe and even more effective than medication abortion care. And, but so we don't want people to make decisions based on pricing alone. We want people to have all of the options that are available to them offered in a very equitable way. So you also have to you need to take a look at the state law, because some of the states are very crafty about being super inclusive about like any drugs that could cause an abortion, which would be interesting because there's a lot of medications that also might have the side effect of causing a miscarriage. So it's going to be a really interesting time, and I don't say interesting as in like a positive, I don't use that in a positive way. It's I would not be surprised if, especially, people of color get targeted in particular for miscarriages, and like questioning, like, what did you do to cause this? And like countries like El Salvador that have had abortion outlawed for some time, there are, many women who are in prison and have been in prison for a long time for miscarriages. And they're usually poor. So it's unfortunately, it's part of the inequities.
And that makes your statistic that you cited about the increase of Black maternal mortality even more frightening.
Yeah.
And to have the fear of going to the hospital, that's not going to help either.
Yeah.
We have another question, which is a medical one. So I'm asking you, even though you're a lawyer, which is, if often now people take home pregnancy tests because, you can get them on Amazon by the dozen, have them shipped to home. If that comes out with a false positive, do you know if these drugs are dangerous for women to take?
Okay, again, I don't have medical advice. There have been people who've done like these political actions where they're not pregnant and they take these medications and they're not harmful. I mean, there's one statistic that, this medication abortion care regimen is safer than Tylenol, and Tylenol is offered over the counter on shelves, and this is not. And so it's just so incredibly safe that it's clear the only reason that there are FDA restrictions on it is that it's purely political.
Another question is if you could talk about the costs of the medications for abortion pills.
Oh, I can do my best. So Plan C pills, if you go on there, they're really great about, finding your state and then listing where you can get pills from, and then the cost of each option. A first trimester abortion, when these are used, because they can be used, FDA approved up to 10 weeks, can be used. Some places and states allow for up to 11 or 12 based on state law and off-label use. I think it's usually between like $350 and $500 is like the average cost. And the Turnaway study, that book that I cited before, which is like, please go read that. That's something else you can do. I don't really like nonfiction books, and I whipped through that one. It was so good. It showed that most people it cited a study that showed that most Americans can't handle an unexpected out-of-pocket, like $400 cost. Like most people can't, and that's exactly how much an abortion costs. And it's very timely. And if you are forced to either save money or find transportation or find childcare, get time off of work or whatever, the barriers just keep building up. And the time you get pushed out, abortion later in pregnancy is still very safe, but the risks do go up and the cost goes up and the time that it takes goes up. And I think we want patients to be able to access care as early as they know that they want and need it.
Actually, I have a follow-up on that, Dana. I noticed that some large corporations have said that they will pay for women to travel or perhaps even get this medication. Is it likely that insurance companies will cover it? Part of your general health plan?
Yeah, a lot of health insurance companies do cover it. I think that that's a great thing to ask that any state that people are working in mandate that insurance companies cover. Some states prohibit insurance from covering or require a rider be purchased in order to cover abortion care, which how many people anticipate that they're going to need abortion care? So I'm very supportive of, corporations offering to pay, but it's also, it shouldn't be necessary, and you shouldn't have to go to I just can't even imagine how awkward that would be to have to go to your HR appointment and to go to your HR to request that. And really, I also want to point out, I mean, it's really good publicity, and I'm very supportive of corporate activism, but most people who need abortion care, I mean, the amount of Medicaid recipients who are seeking abortion care is super disproportionate. And that's what we really need to focus on, is like, these are people who may not be working or may not have insurance or may not have the time off of work that's necessary, don't have the time off of work now, and now they're going to be expected to travel to another state. I mean, it's really, the people that are going to get impacted, it's just really, really, really frightening.
Yeah, it's the poorer women and people of color with no means. This is totally a non-event for people of means. They can fly out of the country if they want, and abortions are not going to stop, which is the real irony of this. It's not going to stop. People are going to get abortions. The ones who can pay have always paid and have always gone to places where they can get them. The issue is for the people without means and people of color who are doubly at risk for not just being pregnant and not wanting the pregnancy, but even giving birth after you're pregnant. So it's a pretty horrible situation, actually, when you think about it.
Yeah. There is an organization called Aid Access that y'all may have heard of, that it operates overseas, and they've been collecting data since Texas went dark, and there are a lot of people accessing pills. It's just a matter of like, are they going to be able to keep up with the demand too? Because I believe they not only, thank you for posting that. I believe that they not only serve Americans, they serve people in other countries. Like abortion is legal in Ukraine, but now all the refugees that are having to flee, especially to Poland, abortion is not legal in Poland. And so now they're having Ukrainian refugee, like I can't even imagine like fleeing from war and finding out you're pregnant. So so it's like the American demand is going to soak up a lot of resources on that end too.
But different kinds of questions coming up. One is, if a woman travels from a state where abortion is illegal and gets to a state where it's legal, such as New York, can she be accused and arrested when she returns to her home state of residence?
So that is a very good question, and I can only say I'm not sure. I think that is a risk. I think there's a lot of unknowns. Some things that we'll need to look into are, I mean, we have the right to travel. I'm not a constitutional attorney either, so this is just kind of like some basic what I remember from law school constitutional law. So we have the right to travel. Like right now, marijuana is not legal in every state, but if it's decriminalized in New York, but let's just say before that happened, like living in New York, any one of us could go to California, smoke pot, do edibles, whatever, and then come back, and we would not be arrested in New York for ingesting marijuana. There's really kind of this, it doesn't tend to happen because we've got this right to travel. And I there's a term I'm forgetting right now about it. So if any other attorneys are on the phone and know this better than me, please jump in. But states may try. There are these right to civil actions that are baked into like the Oklahoma and the Texas bans. Those only relate to abortions that happen in those states. There may also be questions about, I think Missouri did pass a law that wasn't going to let their people travel out, but it's enforcement. How are you going to do that? And then I just spoke with somebody who works for like the National Association of State Prosecutors. I think that's the organization. And the amount of resources that would take is really insurmountable. But I certainly would expect there to be some cases that come up where that is tried, especially, and I would pretty much guarantee it's going to be a woman of color too, because it's just, that's who gets targeted all the time.
And another question is about some language I've seen in articles calling forced pregnancy being what's happening when a woman is denied an abortion. And laws like the 13th Amendment and others that, you know, prevent people from being forced to labor, unquote. Has that got any kind of legal possibility of flipping the script a little on this?
I haven't seen anything on that so far. Yeah, I think, you know, we're looking into, you know, many different, like, you know, denying Americans an FDA access to an FDA approved medication. You know, I think that all arguments are on the table. I think that if you want to talk with your friends about it in that way, you know, I don't think it's untrue. But I haven't seen any direct action or polling or any communications data on that.
Okay, another one back to the medical side. Do you know, in terms of medical follow-up, if it's available if people have complications with medication abortion?
Yeah, follow-up is going to be a big deal. And one thing I forgot to say too is, you know, being prosecuted in your own home state, that is really relevant to this as well. Because if you live in Missouri and you travel to New York, can you, like, if you just get the mifepristone here, can you take the misoprostol back? And is that considered illegal? But what if you do have complications? They're extremely rare, but, you know, where do you seek follow-up care? And there's another organization called If, When, How that has a legal helpline for patients, as well as, and providers can call too, to make sure that they're giving correct information to their patients, where patients can be informed of their legal rights and what they have to tell somebody when they go into an emergency room and what they don't have to tell. Because, you know, you could just go in and say, I'm having bleeding. You don't have to.
Or miscarriage. I mean, miscarriages just happen.
Yeah.
Mm-hmm. So, okay, that is great. Let me look at.
I had one other question, if you don't mind. I was just reading in MedPage, one of these medical newsletters, about the fact that now family practitioners and others are going to be able to prescribe this medication. And I think that's a great benefit, that, you know, where there are no gynecologists, that they are other practitioners that, you know, will be able to prescribe it. And, you know, it'd be great if it came to the point where this medication became an over-the-counter, or at least something that you could get from a pharmacist. I mean, that would just be ideal, and not have to, you know, go to a doctor necessarily at the beginning.
Yeah, I think that, yeah, that's definitely something that has come up as well. Anybody who does desire to prescribe this medication needs to register with one of the the manufacturers as a certified prescriber. I do think it's an interesting idea to possibly expand the scope of practice of pharmacists to do that, because pharmacists are allowed to prescribe birth control in some states. And so if they were, pharmacists could easily, you know, as long as we expanded the scope of practice and it was allowed, and they could prescribe this as well. And then taking off my work hat, you know, and talking about personal, these, you know, views expressed are my own. Yeah, I mean, this drug is very safe. It should completely be over the counter. Maybe someday.
So we do have just 2 more questions, which I think would be good for our timing. One, back to the legal side. How do prosecutors get information on who's taking medication abortion pills? And then how do HIPAA laws play into that idea?
So it can be in various ways. Some states may, mandated reporters for like child abuse and things like that. Some states may mandate that medical professionals report this. The woman who was arrested in Texas within the last couple of months, and then the DA dropped the charges. It was somebody at the hospital she went to that reported her. And you're right that, this is medical care, and it's going to be really fraught, and it's going to turn on what the restrictive states decide to pass. Did I answer the question?
So,
okay. I'm seeing some in the chat, so.
Yeah, a couple things. One was, tell us more about the EMAA project, EMAA, what you're doing now, and in New York specifically, in different states.
So the EMAA project, I mean, it has, achieved its goal of getting the FDA to open up the REMS. So it's going to still look at like what it can do in certain ways, but it's kind of like completed its purpose and is winding down. I am focused on doing some deep dive state analysis into a select set of states to identify what can be done to continue to expand access. And New York is pretty good. I can't speak specifically, but things, to New York, but some things that may, that I tend to talk to people about when it comes to, especially telehealth and making sure people have equitable access to care, especially in the more progressive states, are things like really making sure that it's easy to get Medicaid coverage, that Medicaid truly does cover without reason, abortion care, and that providers can take it pretty easily, that there's not a ton of like hoops to jump through, or like fetal death certificates or things that come up that are just ridiculous that providers end up having to file. Something else that I've seen a lot in states are, when providers take Medicaid, they are required to provide translation services for patients, including via telehealth. And that's often not a reimbursable expense under Medicaid, which I find really interesting. And then also mailing medications may not necessarily be covered via Medicaid. I think expanding scope of practice to pharmacists would be great in states that would be interested in that. And then, there was one more I was just thinking of. I lost it, but those are some issues in more progressive states to really be aware of. Yeah.
So expanding access in the practical sense, and reducing costs and barriers in the practical sense.
Right. Like really making it easy for providers to provide care and patients to access it.
What a concept. That would be great.
Yes, I know, right?
So sorry about the noise. So the question I have then, our title was, are abortion pills the answer? I have a feeling that has many caveats on it, but any final words from you on that? And then we have.
It's gonna help, but the answer is working to overturn outdated state laws. It's going to be changing hearts and minds. It's treating abortion as healthcare, and also understanding that it's not just about abortion, that it's really about the inequities that exist in our system. And, it's one part of addressing all of those inequities.
Mm-hmm. Okay, Colleen, any last words? We have a final slide for action steps, but
no, this has been very informative, and I think it probably helped to allay some concerns about these medications and whether they, would be recommended or not. But from everything that we've heard, they seem to be safe and very effective. Mm-hmm. And I guess it just reminds us, though, of the additional work that needs to be done. As Kate was just saying, they are an answer, but we need many more answers, because this is just one of the issues that we're going to be facing when the Supreme Court makes its final ruling. So thank you very much for all that you shared with us and the ton of resources that you have. It's just amazing. So we're going to try to capture those and make them available to those who signed up tonight. But I really want to thank you for a very informative discussion and look forward to more conversations because this is only the start, I'm sure. So thank you very much, Dana. Really glad
They
that you
need
could join us.
regular legal understanding of how things change on a quarterly basis.
Yeah.
So if you'd stay on, Dana, we do have a last slide if we could have that up because it's action steps. And if you have comments on these, I'd like to hear that. One is just asking everyone to talk about it, talk about reproductive health and abortion care as normal. Two, tomorrow is the next, tomorrow is the last day of the legislative session. And New York, we still have a chance to pass the Equality Amendment. There is good news that there is a bill that passed the House and Senate, and hopefully Kathy Hochul, our governor, will sign it into law, which is called the Fire Hate Act, which is freedom from interference with reproductive and endocrine health, advocacy, and travel exercise. Basically, what it says that it establishes in civil law in New York a cause for unlawful interference with protected rights in New York State. So if somebody comes and gets care here and they are sued and prosecuted in their home state, they can countersue in New York civil court for triple the damages they're charged for in their home state. So hopefully that'll get signed into law. Then donating, that was one of the main things that you mentioned to help patients get the care they need. We have Planned Parenthood locally, but then New York has a series of abortion access funds. And there's a national network of abortion funds to help people with the costs of travel, childcare, all kinds of things. So we'll share that with everyone. And last but not least, please vote and vote to support reproductive health politicians. So those are the action steps that we could think of at the Westchester Women's Agenda. And that concludes our webinar for tonight, but we hope to schedule Dr. Shaw for another event later after things are sorted out with her family. And we thank Dana Northcraft very much. So thanks so much, everyone, and have a good evening.
Thank you.
Bye now.